So yesterday conditions thrombotic thrombocytopenic purpura and hemolytic uremic mean hemolysis plus uremia mean renal failure also include two types thrombotic microangiopathies. This can also cause non-immune thrombocytopenia. This TTP and HUS is a little bit different only. This can cause, as you know, in anemia, microangiopathic hemolytic anemia. The vessels become narrow because of thrombosis, and this can cause lysis of RBC, and the shape will appear as schistocytes. And it can present with increased platelet destruction and can cause thrombocytopenia. It is more severe in TTP than HUS. In HUS, renal failure is more prominent in HUS because this can present with azotemia, increased protein amount in urine, azotemia, blood urea nitrogen level increase, hematuria, and can complain by renal failure later. Because of this, thrombosis can block the renal artery also, and another one is thrombotic thrombocytopenic purpura. This can present with transient neurologic abnormalities. Here you can present neurological symptom can present in TTP because this can sometimes present with thrombotic process in brain. This is quite similar. Some area only different. In TTP, neurological symptom is absent, here present because of their pathogenesis different. HUS is usually followed by E. coli after diarrhea. After E. coli infection, this can be followed by HUS. This is caused by this attempt DS30 deficiency because of pathogenesis is different. So the presentation can be only two different mainly neurological symptom and renal failure. Renal failure quite easy to remember. HUS, hemolytic uremic syndrome. Uremic already included in the name, so that renal failure is mainly predominant in here. TTP is more predominant neurological symptoms. Abnormal distribution, just for knowledge, this is caused by if enlarged spleen condition like in leukemia, lymphoma, this can cause platelet count reduce due to abnormal distribution process in some condition. Dilution effect I already explained, usually occur in transfusion. How many? Massive, because of platelet can be retention in blood, which is storage longer than 24 hours. So I will teach later platelet. If you wanna maintain platelet, you need to the temperature is different, 22 degrees Celsius. Normal blood storage temperature 4 degrees Celsius. Platelet can no longer survive. Platelet function disorder. Previously platelet count disorder, now platelet function disorder. This is quality or quantity? Anyone? This is quality or quantity? Qualitative disorder or quantitative disorder?
Qualitative.
This quality, your function. The count can be normal, the function is abnormal. Previously, all can cause increased platelet retention, so that reduced platelet count can reduce function. Now it's their quality. Count is normal, but not well functioning. It's just for this name, just for knowledge or MCQ, glycoprotein receptor abnormal. Quite rare. I have never seen these diseases. Syndrome, storage pool. This, if you don't just MCQ or this one, just MCQ or just Knowledge not too important because very rare. We have never seen. So I will skip this. Just read by self-study by myself. Not too important for you. Because of very rare in clinical. I have never seen this syndrome. Glassman, PSS, I have never seen. So, nada. Drug effect. This is quite common. NSAID. NSAID. Aspirin, you will teach this NSAID drugs in non-steroidal anti-inflammation drugs. In pharmacology, it's blood. NSAID, non-steroidal anti-inflammation drugs. This can cause example aspirin. This can synthesis thromboxane A2 synthesis, and this can cause platelet acquired qualitative disorder. Acquire means not genetic. This can cause by drugs or sometimes another uremia, liver, uremia, venophilia can also present with
Doctor,
tension.
aspirin can no.
Hello.
Aspirin can cause the platelet not to clot, right?
Platelet function. Suppress synthesis necessary for platelet aggregation. This can cause abnormal platelet function. Not reduce count, just function defect only. Platelet aggregation defect. Platelet function. If you want to platelet can need to aggregate for clotting effect. If here this can suppress this thromboxane A2 synthesis, and this can cause platelet aggregation defect. So this one is necessary for platelet aggregation. So platelet function defect, not quantity, this quality. The function or aggregation function became reduced here. Uremia, why uremia? Uremia, this can also defect aggregation also the same. Uremia in venophilia, this can cause abnormal function, defective aggregation, platelet. Another one, understand? Hello, understand?
Yes,
you will teach this detail in NSAID drugs, side effect of NSAID. Just now, you just remember aggregation defect, platelet function defect is okay. This will teach detail and NSAID function, pharmacological action, pharmacodynamic, pharmacokinetic, and they have side effect. They will teach about aspirin function and NSAID detail in pharmacology. So if currently you just know they can make platelet function disaffect. What function? Aggregation function. Liver can synthesize clotting factor and fibrinogen. And if liver disease, I think they were explained in seminar. Liver disease will be explained in seminar also. So liver disease, what is the liver function? You need to know. Liver function, liver can synthesize clotting factor and fibrinogen. So liver disease can cause DIC as other. This can cause thrombocytopenia and platelet function defect. The details they were explaining, we were discussing in seminar how the two details. Liver disease can also affect thrombocytopenia, and sometimes this can cause platelet function defects. Currently, you remember this? They were discussed detail in seminar how liver disease causes abnormality in coagulation. HIV virus, this can also cause reduced platelet. These are just for MCQ. In thirsty liver disease, they will explain detail. So this is difference between platelet disorder and coagulation disorder. Site difference, particularly here is characteristics, chymosis, Yeah, you need to know characteristics feature. Yeah, characteristics. Because if you see this feature, you should suspect coagulation disorder. If this hematerosis is very rare in platelet disorder. So clotting factor abnormality now can be genetic or non-genetic. So if you complain with bleeding, you need to differentiate according to these features. You can differentiate this is platelet cause or this is coagulation cause. Delay bleeding. Another one, delay bleeding is, for example, after your tender surgery, the bleeding cannot stop for a longer time, is usually due to coagulation disorder. And your experience after tender surgery, you are bleeding not stopping for a long time. Delay bleeding after tender surgery for after a few now the bleeding may delay quite longer duration, and also sometimes initially start then delay later bleeding again like this. Anyway, experience at the clinic you can be okay if they inject some drug and something. Then after that, after a few hours, you are home, the bleeding will continue again. Maybe sometime it's caused by coagulation defect. So 5, you suffer delay bleeding after tender surgery.
Yes.
So you have hemophilia, right? You tell me.
Yes.
You have
So like,
hemophilia.
before surgery, I need to do prophylaxis.
So I think you know hemophilia type. You have hemophilia A or B. What type? Christmassy or you are
A.
classical type? A.
A.
B is Christmassy. Hemophilia B, factor 9 deficiency. Von Willebrand acquired can be caused by vitamin K or thrombolytic therapy. AB is factor 8, factor 9, X-linked recessive, so common in males. Severity is depends on how many levels of factor. So if your level is quite high, mean this can cause hemorrhage secondary to trauma or surgery. If the level is the percentage of the factor in the blood is low, this can cause spontaneous hemorrhage. Moderate, this can present only after secondary to trauma or surgery. This is spontaneous, mean even no trauma, they can cause bleeding. For example, hematerosis. So far, have you suffer hematerosis? No, yeah.
I'm a severe.
Oh, you are not severe. You are mild.
No, I'm a severe. Yes.
Oh, you are severe.
Yes.
You suffer with hematerosis sometime.
Mm.
Your joint began swelling because of bleeding in your joint. I
Yes.
mean, no, right?
Yes.
Yeah, really.
But
Show me if you when you come back to uni, show me if you have hematerosis.
but now because I do prophylaxis, so it's like reduce the chance of getting hematosis.
Bleeding, yeah.
Bleeding.
Or you can do transfusion of fat also, right? You can take blood transfusion, fat only, fat concentrate.
I do it by myself.
It's a difference. I will explain it. You can read later in This is difference between hemophilia AP and von Willebrand. Von Willebrand is not such link. This is autosomal dominant. So I will ask you again, autosomal dominant, how many percentage of disease in family tree? For example, your father and mother have disease, so they are son and daughter, how many percent? They are children.
50%.
Your father, mother have disease. One of your father or mother have disease, so they are children have how many percentage of disease?
50%.
How many percent?
50.
50. This is fertile, fertana, and this is von Willebrand fertile. I will explain later. PWF fertile. Green site is more or less not much different, but here skin include because this can also von Willebrand fertile. If you know von Willebrand fertile, you will know later. This can also affect platelet, stem function of platelet also. So this can also present with skin bleeding sometimes. But mainly must say joint bleeding in this one and this one. Mucous skin can also. PT and already PT prothrombin time is normal. APTT is prolonged in here. Yesterday, PT abnormality, right? You compare and contrast. PT. This can detect extrinsic pathway. So APTT can detect intrinsic pathway. So here, these are intrinsic factor. So this prolonged APTT only, not PT. Beta is normal. Yeah, normal because of this is not platelet cause. This is coagulation cause. Bleeding is normal here, but here can be prolonged sometimes because I will explain later the function of, if you know function of PWF, you will know how bleeding also prolonged in here. Platelet aggregation normal here abnormal because of this disease can affect platelet aggregation also. So that bleeding here abnormal, different from others. And platelet aggregation abnormal, and this can present with skin or mucous membrane bleeding also. This is different from A and B is all similar, just fertile difference only. But von Willebrand is a little bit different from these two diseases. The inside is investigation, PT and platelet aggregation. So this I will later I will little bit explain detail on hemophilia and von Willebrand first. This is more detailed explanation. This two types everybody know, already explained. Sex links, history, male child with abnormal bleeding. Bleeding may be trauma associated. Spontaneous is less common. So, you have no suffer spontaneous, right? You can got bleeding after trauma only, right?
I have suffered spontaneous.
Spontaneous. So you bleeding without injury also?
Yes.
What area? Mucous membrane or bone or joint or where?
Legs, like left ankle.
Give feature. They may need to do abnormal bleeding. Sometimes bleeding can cause anemia. Usually the types of bleeding is warm bleeding. Hematoma within deep tissue. Platelet is superficial. Here deep bleeding and can present with swelling on the joint or limbs or some area and can present sometime after trauma. sometimes after surgery. For example, minor surgery such as tooth extraction. Right? So far you have this like this joint bleeding, no, right? Muscle hematoma and hemarthrosis. This is muscle, this is joint, knee joint bleeding. So you need to compare and contrast with platelet, ITP. ITP, anyone, what bleeding, what area, site? Tell me again, in ITP. PR is this area. ITP, you need to compare and contrast. Idiopathic thrombocytopenia purpura. What area, site of bleeding, sites of bleeding in idiopathic thrombocytopenia purpura. So compare for me. Here is already explained. For platelet, what site of bleeding? What are the sites of bleeding? So anyone, where is
foot temperature? Is it the legs and feet?
What side?
The legs, doctor. Lower limbs.
But it can be. But I mean, not here joint, right? Compare and contrast. Compare for me. What is the site of bleeding from ITP? Anyone? Compare from ITP. To compare and contrast. Otherwise, you will forget and confuse because features are totally different in same area.
Doctor, this is skin and mucous membrane of the mouth, doctor.
Yeah, because they present with skin, right? Skin, petechiae purpura, and some mucous membrane bleeding is more common in ITP. Here, skin bleeding quite rare, and another one, joint bleeding, rarely or very few occur in platelet disorder. Here, joint bleeding is common. Joint bleeding, main point, joint bleeding. Another one, internal organ bleeding, but internal organ bleeding can occur in any platelet or any coagulation can be confused. If it's very serious, they can be missed, but if not serious, joint bleeding and skin bleeding, you can differentiate mainly. Skin bleeding is petechiae purpura is common in platelet. Here is common joint bleeding, more deeper tissue. Another one, epistaxis is common in platelet also. After trauma-induced bleeding after surgery is common in coagulation defect. Yeah, it's the same. It's factoric activity. You need to know investigation, screening. You should know what are screening tests, what are confirmation tests. Pressure tests and confirmation tests. Screening, PT-CT has tests. Clotting time is prolonged because this clotting factor is quite easy. Bleeding time is normal because this is not platelet effect. Hash test is normal because hash test is abnormal in platelet disorder only. For example, dengue, thrombocytopenia. Dengue can cause thrombocytopenia. This can cause hash test positive. You know hash test, right? In dengue, hash test. If you don't know, you can click how to the procedure of hash test in YouTube. Hash test we usually done in dengue patient. Dengue patient hash test is positive. Hash test abnormal in platelet disorder only. Screening though, so in platelet, you need to measure PT, CT, bleeding time, clotting time. Is general in every clotting coagulation disorder. Another one is platelet count. Here, platelet count normal. And peripheral blood flow can be normal or sometimes neutrophil leukocytosis because of reaction. But if you forgot, this is not the problem. Platelet is normal because this is not platelet effect. This is coagulation defect. PT normal, ABDD prolonged, and TT normal. Confirmation test, FATA assay, and TGG, thromboplastin generation test to differentiate FATA 8. Now this is, you need to remember for MCQ1. This generation test can distinguish between FATA 8 and FATA 9. These two, especially these two, this one and this one are confirmation tests. You need to, if I ask in MCQ, the confirmation test for hemophilia is, so you need to answer, need to choose from these two. You cannot choose from this PT, ABDT, and this one, platelet count, clotidine, bilirubin. They are not confirmation tests, they are screening tests only. So you need to differentiate clearly for MCQ. For confirmation test is this. These are screening tests. This is special test. Von Willebrand here. Von Willebrand is that this is a function of von Willebrand. This is a function. They can also mediate platelet adhesion, and this can also stabilize for diet, so that they can present with here. Both bleeding. They can present with both FATA abnormality features, and they can also present with platelet abnormality features, because they have two functions. Wait a minute. Wait a minute. 5 minutes, please. I need to do something outside with the step. Wait 5 minutes. So this is autosomal dominant, and this can affect both sex. This is you no need to know detail. I already explained here role of von Willebrand factor. Okay, friends, I already explained. Where's menorrhagia? The female should know. The guess. Where are the guess?
Doctor, what is the question?
What is menorrhagia? What is meaning of menorrhagia?
Menorrhagia. Abnormal bleeding during menstruation?
Not abnormal, mean increased bleeding. Increase.
Doctor, abnormal bleeding during menstruation?
Abnormal is abnormal, but you need to know, explain detail. Abnormal, what abnormal? Longer duration or increased amount of blood count. Abnormal is for that. You need to explain very detail. Menorrhagia, metrorrhagia, metro and meno, two types there.
Just during menstruation, actually.
Increase of blood amount is menorrhagia.
Yeah,
metro is duration longer. For example, your PDA is 3 days. Metro can be 5 days or 10 days or longer duration. Menorrhagia mean increased amount. So you can present with anemia later. You got bleeding a lot.
Excessive loss of blood during menstruation.
So menorrhagia can present with what type of anemia? Anyway, correlate what type of anemia? What type? Different type, 2 million type anemia, hemolytic anemia or deficiency anemia or immunemia or what type?
Blood loss.
Blood loss can cause what type? What type? Different, too many classification of anemia. So what type and this classification? Blood loss correct. What type? Longer, acute blood loss can present with anemia or not. You need to know the concept. Acute blood loss can present with anemia or not. For example, you blood loss today. For this time, this month you have menorrhagia. When you check for hemoglobin, you can present with anemia or not. You should know. If you in the longer duration, a little bit immediately anemia can after it takes at least 24 to 48 hours. For example, you have blood loss currently, you got injury, accident. You check immediately. Hemoglobin percent will be normal only. Maybe sometimes increase because of blood need time for some changes. After 48 hours, you can see reduced hemoglobin percentage. Menorrhagia is what type of anemia? What type? Deficiency anemia or blood loss is correct. Another. After you have menorrhagia for 4 months, for what type of anemia will suffer this moment?
Doctor, IDA, correct?
IDA, iron deficiency. If 4 months, immediately cannot suffer IDA. After a long time, 4 months can suffer IDA. Not B12 and folic acid, not hemolytic, not cool and warm, quite different. Investigation I already explained. Screening test, confirmation test. Here, Hess test is positive. Why? Hess test here positive. In hemophilia, Hess test negative, right? Why here Hess test became positive? So anyone, I already explained what is Hess test. I already explained what is Hess test. Just now, I already tell you. Hess test is here why Hess test became positive. If you cannot correlate their pathogenesis and their investigation, you will forget positive or negative later. If you consider logically, you will never forget. Why anyone? Why is Hashim? Why is so silent? Sham, so silent.
Hello.
Why has test became positive here? Previously, hemophilia negative, right?
Doctor, is the platelet function is impaired, right?
Yeah, because of platelet. Because test is usually measured for platelet. For example, dengue. I already explained with dengue, right? Dengue has test positive because dengue patients suffer thrombocytopenia, reduced platelet count. Here is not reduced platelet count, but platelet function defect. This can also cause platelet function defect. So this can present with platelet not well function. The same feature with thrombocytopenia. Even they have normal count, no quality. So if you do has test positive, so quality and quantity, if reduced thrombocytopenia and function defect, the clinical feature will be the same only, because of it in function defect, even the platelet amount is normal, they have no quality, no function, so useless only. They cannot prevent bleeding. Another one here is platelet adhesion function test will be defective or absent, because of this can mediate platelet adhesive function. Pressure test, PT, ABDT, DT. Here also, the type is reduced platelet adhesion defects. So I will teach you now clinic how to approach patient. Firstly, you need to know what is bleeding. Is bleeding real or not? You need to trace another one.
Yeah.
Hey, anything? Huh? What sound? What voice I'm hearing? So it's due to vascular problem, or this is genetic or non-genetic. What test is bleeding real? You need to as history, menstruation, bruise, surgical, blood transfusion. It's deficiency of due to platelet or coagulation defect. Because of platelet and VWD present with mucocutaneous bleeding. Coagulation present with soft tissue joint bleeding. Both can present where bleed from injury or at the time of surgery. So you need to ask the history, and you differentiate the type. You need to differentiate this acquired or inherited. You need to differentiate this is vascular disorder or not. And test ABDT, PT, TT, and PT. They can detect according to their pathway. Bleeding time can detect platelet function. Full platelet count, you can know platelet count and morphology. GIC screening test, FTP, fibrin degradation process, and DD timer. I will teach now this one. Especially like this, platelet, then this is only quite easy. This how to approach is just for knowledge. For platelet coagulation disorder, important is important in clinic is ITP, hemophilia, and von Willebrand. These are important in clinic, quite common. But most important is ITP. ITP is very common in clinic. Hemophilia also quite common. This two is most important. You must know. Bone weary band is sometimes we can see. But IgB hemophilia, IgB, especially IgB, you guys see clinically a lot. IgB in children. Sometimes you can see HUS sometimes, but sometimes only. So I will continue with TIC. TIC also quite common in clinic. So you know what is nice? What is TIC? TIC here. You need to know this, but we first why FTP is increasing TIC, because TIC definition, this is outline, this is something you need to write time yourself. This is I already teach general classification of bleeding disorder. Platelet count of blood vessel count, platelet defect or blood vessel defect or coagulation defect. Coagulation can be genetic or non-genetic. This non-genetic can be vitamin K, inhibition of coagulation, or DIC also. Now, DIC, what is DIC? DIC is widespread intravascular coagulation. So formation of microthrombi in the body. So the whole organ, the whole body cause widespread intravascular thrombus. Then followed by depletion of coagulation factor and platelet, because they use a lot of this coagulation factor in microthrombi formation. Then followed by fibrolysis and hemorrhage. Because of this thrombus need to destroy later, so became fibrolysis, and because of depletion of this factor and platelet, they can follow later by hemorrhage. So hypercoagulation followed by hypocoagulation. Firstly, they use a lot of platelet and clotting factor for coagulation. Then later, all factors are finished in the body. So body is followed by hemorrhage. Initially, hypercoagulation followed by hypocoagulation. So this systemic activation of coagulation, this can cause intravascular fibrinolysis, thrombosis. Firstly, thrombosis, so this can cause organ failure. Secondly, followed by reduced platelet and clotting factor. This can cause bleeding later and can suffer death. This is general principle of TIC. Causes. What are the causes of TIC? Very common is here. OG, O complication, not G. Obstetric complication, embryonic fluid embolism, abrasio placenta. These are very common in clinical. And I mean, obstetric complication, not embryonic is quite rare, but can fatal. Abrasio placenta sometimes we can see, but most common TIC common causes sepsis. In clinic medical ward, you can see septic shock, and other OG ward you can see O complication. These two I have seen frequently. These two complications can cause TIC, sepsis and obstetric complication. Others also can see, but I have seen in hospital these two quite common. Malignancy sometimes relation to toxin snake, especially viper. You know viper and cobra, right? Viper and cobra. Have you know the snakes? Yes. Anyone in the student? Yes. Anyone in the student? You have python at your home?
No.
You have?
No.
You don't have. And I will. You like python, right? Python, the beautiful python, white gala. Ben Yoshan, you have python at your home? Ben, where is Ben?
No.
Python. What pet you have? Dog or cat or snake? Who have Python? I think Shan will like Python. Shan or Melissa. No have Python at your home.
Shamuddin. Ishan.
Yeah, Vishan. Shan, you have Python at your home? Who likes Python?
No.
Because nowadays people Python as a pet, quite beautiful, but I don't dare to touch them. So this how this goes. Another one, heat stroke. But in Malaysia, heat stroke is not common, right? I think heat stroke. You know heat stroke, right? Heat stroke. STR. Heat stroke. My country quite common in summertime. Heat stroke. Environment temperature too high. Here not more than 40 degrees Celsius, so no problem in Malaysia. My country more than 40. In now currently summertime 45, 46, 47 degrees Celsius. In some part of my country is very hot in summertime, so the heat stroke quite frequent in my country. I still remember less 10 years ago, 2010, heat stroke is spent very, I'm going to say, cause of death in my country. This very hot, record hot in my country. This we suffer a lot of heat stroke patient in the hospital. Pans, vasculitis can cause endothelial cell injury, and this can cause tissue factor activation. This can cause TIC. This just for knowledge only. These are precipitation factor. Or another one, pathogenesis. You need to know this one. This is just for knowledge, but you need to know this one. The same mechanism. This destruction, sepsis, injury cause tissue factor release. This can cause widespread thrombosis. This thrombosis cause or can become ischemia. Damage. They also concern a lot of clotting factor and can follow by bleeding. Another one, you need to lysis this thrombus. This can develop plasma and fibrolysis, so you can detect fibrolysis products in the blood. Morphology. Morphology is quite easy. Thrombus. Thrombi in every organ. If adrenal involvement, Waterhouse Friderichsen syndrome. If you kind of remember here, okay, this way, and this one already teaching microbiome, right? Microbiology. Waterhouse Friderichsen syndrome. Adrenal failure in what meningococemia, I think. Have you teach meningococemia in microbiology? Meningococemia. Waterhouse Friderichsen syndrome. Adrenal failure. Have you finished in microbiology? Waterhouse, I think already finished because this is because meningococci can also cause this syndrome also. Meningococemia, I think meningococemia can also cause acute adrenal failure. Caused by severe bacterial infection. This is cause acute adrenal failure. Because here this can also cause acute adrenal failure because of thrombus. Thrombosis cause ischemia adrenal. This can also cause Waterhouse Friderichsen syndrome. The features is the adrenal gland cannot well function. Meningococcus can also cause this syndrome. Hey, I want to know microbiology teaching already or not?
Yes.
Don't
Why so silent? Sleeping.
Oh. Oh. Is it like hello? Hello?
Hello?
Hello?
Okay.
So coagulation. Hey, why became 5 hours? So clinical features. Acute DIC, chronic DIC. Acute DIC is bleeding manifestation, the same only. Chronic DIC can present. Chronic DIC, if you quite rare. Acute DIC is quite common. Chronic DIC thrombosis. This can cause short renal failure and coma. DIC is quite serious, usually fatal. Anemia type and MAHA, microangiopathic hemolytic anemia. Laboratory tests. Complete blackout. Anemia. What type? Pneumochromatosis anemia. If you have blood, you can see schistocyte because of this is microangiopathic because of thrombus formation in the vessel. This can cause vessel begin narrowing. Microangio. Micro means small, angio means vessel. Small vessel can cause hemolytic anemia and MAHA. Count reduce. Test for coagulation defect. PT. The same only PT, TT, fibrinogen concentration. Here is, I will show later. This is coagulation factor per way. If you want to detect factor 8, you can detect ABDD. You see right? Factor 8. You can test with ABDD, intrinsic factor.
Yes.
Extrinsic factor, what you want to do? PT, prothrombin. Here, if you want to extrinsic factor, want to detect, you need to do lab test PT and INR. Intrinsic ABDD. Common pathway TT thrombotine. Hemophilia, so ABDD prolonged, PD normal because hemophilia is intrinsic factor deficiency, not extrinsic. Okay. Fibrin. Here, fibrin clot. This clot are destroyed by fibrinolysis, and so here FTP. So you must know FTP is increase in DIC because thrombosis followed by fibrinolysis, and D-dimer also increase in DIC. This test is quite important for DIC. In laboratory, if you want to know the patient DIC or not, these tests are supported only. This FTP and D-dimer is more specific for DIC, more confirmation. These are generally, you need to do this is general laboratory test for hematology test for bleeding disorder. This is, if you want to know the patient DIC or not, you should check FTP and D-dimer. So you need to compare and contrast hemophilia, what test is confirmation, what is screening, ITP, what is screening, what is confirmation, and DIC also, what test is supported, what tests are confirmation, or what tests are more important. You compare and contrast also. In leukemia is quite saying, or immunophenotyping heterogeneity are more specific for diagnosis. Here, platelet coagulation, you need to know different compare and contrast and repetition. Otherwise, you will confuse if you write D-dimer positive in ITP, totally wrong already. If you write factor assay in DIC, wrong also. Factor assay is not too important. I mean, still we can give math, but not specific. If you forgot this two, you should not be forgot this two. Must not forget. This two is important. In laboratory, when you arrive hospital, the physician will ask you what test you will do. If the you suspect DIC, you should do FTP and D-dimer. Usually D-dimer we use in clinic. I'm not sure. It depends on hospital, I think. these two tests you must know for TIC. So this is a test for fibrinolysis. D-dimer sensitive but not specific for TIC, but we do a sensitive. If D-dimer increase, you can suspect TIC, but not too specific. Mean they can increase in other fiber defect also. So, but usually in clinically we do D-dimer and FTP usually. If you are sensitive specific, if you forgot, okay, you are level just know TIC in clinical, we do D-dimer and FTP in clinical. Always do. Yes, acute pronate. I already explained. Prognosis is especially life-threatening. Mortality rate quite high. 40 to 80% can die. So TIC is important. Treatment only for you. Treatment is for and medicine. Case study: car accident, spleen fracture. After a few hours, profuse bleeding was needed to accommodate and puncture sites of all bleeding from all puncture sites of IV line. If you see this feature, you can suspect TIC. Profuse bleeding from abdominal rings and puncture site. For example, you are especially cannula site and IV line site bleeding. You can see, and then lab test, hemoglobin reduce, anemia, platelet count reduce, PT. Or in TIC is quite easy. All count are prolonged, all time is long. Here you can see TIC. APT prolonged, PT prolonged, platelet count reduce. All count are reduced, all time are prolonged. In compare with other all time in PT, APTT, PT, or TT all are prolonged. INR here. Prometa, ABDD, PD, INR, all were prolonged in TIC. Bleeding time, all were prolonged. And count, platelet count reduced. TCD increase is not too critical. Just if you confuse, it's okay. If you can need to remember this PT, ABDD prolonged, platelet count reduced. Fibrinogen reduce, this is quite easy to remember. Another one, D-dimer increase. Soluble fibrin monomer complex increase. So here, fibrin degradation process is increased here. So after this lab test, you can confirm TIC. So I'm not sure. And this time, especially in pro exam, we can ask with scenario. Yeah, also if scenario, hopefully, if I ask, you can answer. And this clinical feature, this is the main point for diagnostics. Main point is here. Profuse bleeding from abdominal rings, and if you don't know abdominal rings, puncture sites. These are main point, and this is history after fracture and attack trauma, and splenectomy because of rupture spleen can present.
Doctor, just now you mentioned cannular sites, is it?
Yes, cannular site.
So is that
intravascular site line is usually IV line from cannula, right? We use cannula for IV line.
Okay.
Puncture site mean IV line from IV line. cannula side, because we use cannula for IV infusion in hospital, right? We don't use the needle injection. And we always use cannula in hospital for IV line, because usually disposable needle is quite small cake. Cannula is big cake. If you wanna for hospitalized patient for rapid transfusion of fluid, you use cannula, the cake, the color. If blood, we use green color. Normally, we use yellow color. I'm not sure. I think green color is for blood transfusion cannula. And fluid usually pink color, not yellow, pink color. Yellow is for children. Pink color. Here, I'm not sure. My country, we use green color cannula. We can see this is for transfusion cannula. And pink color, this is normal cannula for IV line only. Antibiotic and fluid. For blood, we use more bigger side, green color. So, okay, tomorrow I need to continue blood transfusion. Blood transfusion and some MCQ. On Friday, Thursday after seminar, I will practice some MCQ. So I need to, as tomorrow meeting, I need to ask. Tomorrow I have class also after 10 to 11:30. 11:30 I need to attend meeting. Then after their meeting, I will inform you. I will ask in Miss Sam MCQ or and usually MCQ. If I need to choose the method, if just like assignment, but then only I can give for MCQ and I need to try to test office assignment how to upload. Then MCQ, maybe if MCQ only, I will ask 20 only. And if assignment I'm not too sure, I need to ask on meeting. If Kahoot, if MCQ only 1 minute, but I think if connection, your connection not good, you will got problem. So I'm not sure. And tomorrow I will do some trial. If not okay, tell me. I think I have better do the assignment method, but then or using Microsoft Teams, giving 1 hour and start and send and scan me via email. I can also do also. Microsoft Teams assignment. I can also do, I think. I need to ask the tech or IT. Then if I can do, if Office, I will use Office, and then in Office I will show questions for 1 hour, make quiz 1 hour, right? 1 hour after you finish your photo, and I think your phone, all your phone can do scan, right? You can download application. You can download application very easy in phone. Then you can scan with your phone and you can send me email. Right? Every phone can be scanned, I think. If you just download application only, and you can scan with the phone and you can send email your answer. So okay, finish. Today important DIC need to know another 2, hemophilia and ITB need to know. These 3 are important in clinical. It's very common in clinical. So bye. See you tomorrow morning. Tomorrow I'm a little bit early. I'm start. Tomorrow a little bit early. Round about because I have meeting.
How early?
Round about 10 a.m. I can start. Okay, right? 10 a.m.
10 doctor.
10 I will start meeting 11:30. Okay.
Okay.
Bye.
Bye.
Thank you, doctor.
Right, bye, Ocean. Where's Ben?
Yes, doctor.
Okay. If I need, I will from you. Bye.
Okay.
Tomorrow, please read a little bit fast. So for you, please collect wonders along with you, so you can try MCQ. Okay.
Doctor, this one is until neoplasia too, right?
Yeah. This Miko is and then neoplasia too only. For tomorrow is MCQ is not exam. Tomorrow is just try it and just teaching only. Tomorrow is Friday. If exam maybe in Friday, Friday is exam. 1 hour only. If exam Friday 2 hours, if Friday not okay, if I have time, I will use Monday evening or something. Let me check first. If I can ask with pharmacology, if the pharmacology Monday evening free or not? Pharmacology, I want to know. You have class or not? Pharmacology.
We have no idea.
No, you got timetable or not? Haven't got timetable. Pharmacology.
No, not yet.
Not yet, doctor.
Not yet, doctor.
Because if let's see if I got time, I need to do in this Friday. Let me check if I need to ask pharmacology lecturer. Then if he can give me, if he is free on evening, I can take one time from next week, one evening, like Tuesday evening or Monday evening, I can take for exam. Because I need to prepare. I have to prepare, already finished preparation, but what method I have to use is quite. I need to ask if Kahoot. I haven't prepared for Kahoot. I need to prepare Kahoot. If no Kahoot, okay. But I'm worried if the Hashin tell me that Kahoot not okay in the class, right? Well, one question is if your connection is slow. If you cannot answer and then 1 minute finished it, already change another question, and then quite difficult. But for me, it's quite easy because if you finish 1 hour, then you are maths already and got all the student maths I already got. No need to making for me. You are all maths are key already there. Why? But for you, if you have no slow connection, if you cannot answer in time within 1 minute, for example, your connection lost again. Cannot finish, your maths will all lose. So I want to try it first. If you are not okay, just do Microsoft Teams. I need to try both Microsoft Teams and Kahoot. And Kahoot maybe not okay. How about your suggestion also? Kahoot, you like or not? Shane.
No. We don't like Kahoot.
1 minute. 1 minute. I mean, I can give 1 minute for 1 MCQ. 1 minute. 20 MCQ. 20 minutes finish. Already finished. If you have.
No.
Okay. I'm trying with another method first. Okay. Bye.